Well, good afternoon. Welcome to this month's session of the AAST Virtual Grand Rounds, which this month is being hosted by the Geriatrics Committee. This month's session is titled Geriatric Trauma Triage. Does it matter and when do you do it? I am Jody Digiacomo, and I will be your moderator for this panel discussion today. I am the Director of Surgical Critical Care and Associate Director of Trauma at Nassau University Medical Center in Long Island, and also wear the hat of Director of Geriatric Surgery. The question of geriatric triage is significant for us. Our catchment area is Nassau County, which has a population of 1.4 million people, of whom 9% are aged 80 and above. However, the same age group constitutes 20% of our trauma admissions, and as a result, we've had to make a number of modifications to our routines to address the specific needs of these patients. One of which is to have a default admission location be the surgical ICU, which of course has its own collections and consequences. While this approach has worked well for us, our broad swath approach to geriatric trauma triage is clearly not ideally a solution for everyone else. So to help us address the challenges of the injured elder patients, we have three trauma surgeons as our panelists today. Our first speaker is Joseph Poslunszny, who will be discussing the benefits of aggressive triage strategies. He is an assistant professor at Northwestern University Feinberg School of Medicine in Chicago. He practices trauma, critical care, and emergency general surgery. Our second speaker is Jennifer Knight Davis, I apologize, whose topic is Triage is not the answer. Dr. Knight Davis is an associate professor of surgery at West Virginia University. She serves as the trauma director at the John Michael Moore Trauma Center, a level 1 center that cares for injured patients in West Virginia, Eastern Ohio, Southwestern Pennsylvania, and Western Maryland. West Virginia has the third oldest population in the United States, with 20% of its population older than the age of 65. Our third speaker today is Sasha Adams, whose topic is You Do You, which I think everyone will enjoy. Dr. Adams is an associate professor of surgery and general surgery program director at the McGovern Medical School, UT Health in Houston. He's a trauma surgeon at the Red Duke Trauma Institute at the Memorial Hermann Hospital in Texas Medical Center. And then finally, we will finish up with questions and answer period for the panelists. As we're going through the lectures, please put your questions into the chat section so I can see them and direct them to the appropriate discussant. So I guess at this point we will get started, and I turn things over to Dr. Poslunszny.
Hi, I'm Joe Poslunszny, and I'll be presenting the benefits of geriatric trauma triage. None of the presenters today have any disclosures. In order to make my argument that geriatric trauma triage is beneficial, I'll frame my argument around three common questions about triage and their associated goals. First, why triage? With the goal to ensure proper injured patient disposition and resources. Next, should age matter? With the goal to ensure proper resources for geriatric patients. And lastly, how should care change for geriatric trauma patients? With the goal to ensure best outcome for geriatric trauma patients. As I present the literature on geriatric triage, it will all be framed to answer these questions. Triage is often thought of as field triage of injured patients prior to arrival at the hospital. For this entire presentation, in addition to the presentations of Drs. Knight Davis and Adams, we're going to refer to geriatric triage as triage decisions made not only in the pre-hospital setting, but also upon arrival to the trauma bay and once admitted to the hospital. We will use consistent terminology to distinguish between pre-hospital triage, trauma team activation, and in-hospital care pathways once the patient is hospitalized. We will start with pre-hospital triage. The inability of geriatric patients to respond physiologically to traumatic injury in the same way as younger patients is apparent in a 2009 study using state of Washington data. They looked at all patients who underwent a trauma evaluation and divided patients into quartiles based on age. When they examined field triage heart rate and blood pressure, they found that older patients presented with lower heart rates and higher blood pressures than younger patients. This trend was significant and true for both all patients and patients undergoing urgent emergency room interventions or direct transfer to the OR. The authors also looked at the impact of under triage and age. They defined an under triage patient as one who needed an urgent emergency room intervention or transferred directly to the OR or ICU without full trauma activation. When under triage, patients were divided into geriatric or not geriatric, and outcomes of mortality, discharge GCS, and complications were compared. These outcomes were 15 to 16% worse in the geriatric age group. Together, this study demonstrates that heart rate and systolic blood pressure may not change in geriatric patients, resulting in these triage physiologic variables being less useful in the triage of geriatric patients, and that under triage of geriatric patients is associated with worse clinical outcomes. In fact, multiple studies support the notion that older patients may have a blunted physiologic response to injury, making use of heart rate and blood pressure less reliable for pre-hospital triage in geriatrics. So if we know that older patients have a blunted physiologic response and worse trauma outcomes, are geriatric patients being under triaged? A study from 2009 using data from 105 hospitals in the Western United States asked if current field triage conditions under triage older patients. The authors considered under triage as a patient having a missed serious injury corresponding to an ISS of greater than 16, and patients were divided by deciles of age. As seen in the figure here, the authors found progressive increases in under triage with age starting at the age of 60 and worsening with greater age. This study, in addition to several others, found that under triage increases with increased age. Combined with a blunted physiologic response in geriatric patients, age alone and standard physiologic parameters may not be sufficient to modify trauma triage to appropriately identify injured geriatric patients. The current combined American College of Surgeons Committee on Trauma and CDC field triage guidelines somewhat address this concern, but not with much specific guidance. Not until step 4 of the triage guideline does it acknowledge age, only stating to recognize that age greater than 55 may be associated with higher risk, that a blood pressure less than 110 may represent shock in those over 65, and that low impact mechanisms may be associated with more severe injury. In order to better triage geriatric patients in the field, some states and trauma systems have added geriatric specific trauma triage criteria, with the state of Ohio having one of the most studied criteria. This study presented here is from 2015 and is a review of over 100,000 adult trauma patients in Ohio from 2006 to 2011, and compared how the geriatric trauma triage Ohio modification compared to standard trauma triage criteria. They use age over 70 to define geriatrics and appropriate triage to define geriatrics. An appropriate triage to a trauma center was considered an ISS of greater than 15, an OR visit within 48 hours, any ICU stay, and inpatient mortality. The geriatric and standard triage criteria are listed in the table to the right, with key differences being a systolic blood pressure threshold of 100 rather than 90 for geriatric patients, a GCS of less than or equal to 14 rather than less than 15, and adding the criteria of fracture of one long bone in an MVC, injury to 2 or more body regions, any pedestrian struck, and any fall with a TBI. The table here lists their results. The authors determined the sensitivity and specificity of identifying serious injury, divided into geriatric and non-geriatric populations, using both the geriatric specific and standard trauma triage criteria, and found differences in sensitivity and specificity with the use of both criteria. They found that the use of geriatric trauma triage criteria led to improved sensitivity for geriatric patients with acceptable decreases in specificity for all outcome measures. While many states and trauma systems have separate geriatric triage criteria, the best practices of those criteria are unclear. A great recent systematic review sought to determine the best practices. They reviewed 11 studies of which a variety of data sources were used, including the Ohio criteria, NTDB, national automotive data, and state databases. Studies use different age criteria to define geriatrics, including greater than 55, 65, and over 70 years old. These studies also use quite different triage criteria, including changes in blood pressure, with some using a systolic blood pressure of less than 110, some less than 100, and some less than 90, heart rate of less than 60 or greater than 110, different mechanisms of injury, and different criteria for anticoagulation use. In addition, an ISS of greater than or equal to 15 is often used as the gold standard to determine if a serious injury was identified. However, most concerning may be that only one study actually looked at a clinical outcome. As all of these studies have, they concluded that geriatric trauma triage criteria increase sensitivity with acceptable decreases in specificity. Ultimately, though, there is not a best practice. There's been too much focus on aligning with injury severity measures and too much variability in triage criteria and age cutoffs. More research needs to be done focusing on patient outcomes to make these triage modifications more clinically relevant. So we've clearly shown the benefit of pre-hospital geriatric trauma triage, and we'll move on to triage of the trauma patient once they reach the hospital with trauma team activation. The best study investigating trauma team activation for geriatric patients is a 2019 study from Los Angeles, where age greater than 70 years old and an injury mechanism led to mandatory trauma team activation. They retrospectively reviewed 5 years of trauma activations and divided geriatric patients into those who only met age criteria and those who met standard trauma team activation criteria, which were systolic blood pressure less than 90, heart rate greater than 110, GCS of less than 9, a gunshot wound, or blood transfusion. Appropriate triage was considered if the patient had a mortality, ICU admission, intubation in the trauma bay, an IR or OR procedure, or an ISS of greater than 15. They found that 27% of patients met standard trauma team activation, while the remaining 73% had activations for age alone. The over triage rate was 40%. However, standard criteria for triage missed many seriously injured patients, as age alone patients had a 9% mortality, 27% had greater than an ISS greater than 15, 56% were admitted to the ICU, 13% were intubated in the emergency room, and 12% underwent an urgent OR or IR procedure. Therefore, this study clearly shows that adding age greater than 70 reduces under triage with acceptable over triage. So we've shown the benefits of both pre-hospital geriatric specific trauma triage and trauma team activation. Now we will address what geriatric specific care can benefit patients while hospitalized. One of the difficulties with triaging geriatric patients is that geriatric patients of the same age can differ tremendously in their fitness and comorbidities. In the field and in the trauma bay, this rapid assessment can be especially difficult. However, in the hospital, we have the luxury of time and access to information. One method of stratifying geriatric patients is based on their degree of sarcopenia and osteopenia, with the thought that muscle mass and bone structure are associated with overall fitness. The study here is a retrospective study from 2011 until 2014 at the University of Washington that compared the outcomes of complications, length of stay, disposition, and mortality in trauma patients over 65 who underwent a CT scan of the abdomen. Sarcopenia was defined by the volume of the psoas muscle at L3 and osteopenia as the Hounsfield units at L3. As seen in this Kaplan-Meier curve, the survival for geriatric patients with osteopenia, sarcopenia, or both osteopenia and sarcopenia were significantly decreased in comparison to those patients without sarcopenia or osteopenia. This demonstrates that we can use something as simple as CT scan findings to determine who may have worse outcomes in this population. While sarcopenia and osteopenia require a CT scan, we can also screen patients for frailty. One of the first of many studies to recognize the benefits of frailty screening in geriatric trauma patients was a prospective study from 2011 to 2013 at the University of Arizona, in which a frailty index was measured for all trauma patients over 65 years old. There were 250 patients with a mean age of 78, and frail and non-frail patients were compared in terms of complications and adverse discharge. The frailty rate was 41%. They found significant increases in sepsis, hematologic complications, pulmonary complications, as well as increased length of stay and more adverse discharge dispositions for frail patients in comparison to non-frail patients. On multivariate analysis, they also found that frailty rather than age was associated with in-hospital complications, So putting this all together, we have methods of frailty measurement and sarcopenia that can flag geriatric patients at risk for worse outcomes. Since we can now recognize frail patients after admission, we should be able to improve their outcomes. A 2019 study from Brigham and Women's Hospital sought to determine the effect of both frailty screening and a subsequent frailty pathway for patients deemed frail on the outcomes of delirium, complications, in-hospital mortality, and 30-day readmission. Patients were screened using the 5-item frail scale. The frailty pathway included early ambulation, non-pharmacologic delirium prevention, a bowel and pain program, nutrition, PT, and geriatric assessments. About 90% of the patients screened as frail. They found that the post-intervention group had a 9.1% absolute risk reduction in delirium and a 6.8% risk reduction in 30-day readmissions. Together, this study, as well as several others, demonstrate that frailty screening and frailty pathways can improve geriatric patient outcomes. So in summary, we have shown that for pre-hospital trauma triage, geriatric specific triage better identify geriatric patients with higher ISS, and that over triage is worth the effort. In terms of trauma team activation, we've shown that trauma team activation improves under triage with acceptable over triage. Lastly, and most significantly, while hospitalized, frailty screening and institution-specific frailty pathways improve geriatric trauma patient length of stay, readmission rates, and disposition. So going back to the goals of triage, to ensure proper injured patient disposition and resources, yes, geriatric trauma patients should have different pre-hospital triage markers. In terms of age mattering, yes, age should be an initial marker for higher pre-hospital and trauma team activation, in addition to age-appropriate physiologic variables and injury patterns. And lastly, to ensure best outcomes for geriatric trauma patients, in-hospital frailty screening and a frailty pathway should be part of all trauma programs. Thank you.
Well, thank you, Dr. Poslunszny. That was very, very good. Very interesting. Now we have Jennifer Knight Davis with a bit of a counterpoint view. Triage is not the answer. Dr. Knight Davis.
Thank you. Dr. Poslunszny has brought up some valid points. I must disagree, however, for the purposes of learning. As a lover of old people, I'm here to explain that it's what we do to treat injured elderly patients in the hospital and not what happens necessarily in the trauma bay that makes a difference. We know that elderly injured patients do better when they are cared for at a trauma center. We also know that an injured 84-year-old with a fractured femur will not handle this injury the same as a 48-year-old and will not do as well. There are physiologic changes that occur with age, as well as multitudes of comorbidities and medications that make taking care of this population of patients a challenge. Changing triage criteria for the elderly has been suggested. One study by Barry reported that systolic blood pressure less than 110 should be considered for triage, as it increased mortality by twofold. The standard triage metric of systolic blood pressure at 90 for the elderly remains validated as an accurate predictor of mortality and can still be used based on our triage criteria. To evaluate the effect that a modified triage would have if blood pressure and heart rate were adjusted, 3,600 injured patients in this study were examined and assessed for cost effectiveness. The outcomes of these patients were known and analyzed retrospectively. A model was applied with triage adjustments. This modeling would have resulted in an increase in patients who were found to be severely injured and facilitate their transfer to a trauma center. But there was also a significant increase in the transport of patients to trauma centers who were not severely injured. The result of applying a more conservative triage criteria and the ultimate outcomes in patients cost $1.2 million per acquired quality adjusted life years in these patients. The authors concluded that a high sensitivity field triage criteria for identifying severely injured older adults was not cost effective compared to just using current field triage practices. They recommend focusing on appropriate transport of traditional triage positive older patients to trauma centers. So what about the trauma team and its activation for an elderly patient? Utilizing a full trauma team activation has been proposed by multiple authors, but begs the question of effectiveness of this compared to the increased cost on the patient in trauma activation fees and the stress of the hospital resources from an increase in over triage. One institution sought to determine if full trauma team activation influenced elderly injured patients. Indiana University changed the trauma activation criteria and made age of 70 a criterion for full trauma team activation starting in 2013. As a result, 2,400 patients whose age was greater than 70 had full trauma team activation upon arrival to the trauma center. The primary outcomes of the study were mortality and length of stay. When the patients who had full trauma team activation based on age was compared to the standard triage group, there was a significant increase in the number of full trauma team activations, but not a benefit in mortality. In this population, the over triage rate would be increased, thus diluting the mortality of the severely injured patients. Despite this, there was not an improvement in mortality. Subsequent analysis of the data and another paper published from the same cohort of patients, there was noted a small improvement in the time in the emergency department, but that was overall in a small number of patients. The trauma activation costs at this institution was $21,000 per full trauma team activation. For a partial trauma team activation, the activation costs were $15,000. There were 1,600 patients who were identified as being over triaged in this study at a cost of almost $10 million. Due to concern about our elderly patients, we embarked on a similar experience and changed our triage criteria for elderly patients to add age greater than 65 as a criterion for full trauma team activation. As a result, we also saw a significant increase in the full trauma team activations in this group. We saw an overall decrease in mortality in these patients who had full trauma team activation based on age alone, but when the intervention year was evaluated, the mortality in those patients who met traditional triage criteria matched that of the normal treatment group, thereby showing that the mortality advantage of the intervention year was a result of dilution from those patients who were over triaged. For the patients who received full trauma team activation due to age alone and did not meet standard triage criteria, their ISS was lower, Glasgow coma scores higher, hospital and ICU length of stay was shorter, time in the ED and trauma area was longer, and they had less interventions, including procedures, fluids, blood while in the resuscitation area, and less fluids overall. Therefore, showing us that there was no appreciable benefit to full trauma team activation in these patients. What we did see was a high attrition rate with 49% compliance at the end of the intervention year with full trauma team activations. Sadly, 4 to 5 months into this experiment, the excitement of the trauma team was affected when the page came high alert 84-year-old fall from standing compared to high alert 24-year-old fall from standing. Readiness was lost by the protocol as the year progressed and the numbers dwindled through the year as various practitioners deviated from the protocol. Like the previous study, our analysis of cost also showed the high price of over triage without a mortality benefit. The Eastern Association for the Surgery of Trauma has drafted recommendations on this topic. They recommend that elderly injured patients should be treated at trauma centers. A threshold should be lower for trauma activation in elderly patients without a more specific recommendation. And initial aggressive patient care should occur with these vulnerable patients. It's not what happens in the trauma bay, it's what happens in the hospital. While this study focused on the very elderly, those greater than age 89, they found that the admission to the trauma service and not necessarily the activation was key to a decreased ICU and hospital length of stay without a mortality benefit. Dr. Poslunszny and colleagues add to this argument and have demonstrated that when frailty of trauma patients is addressed while in the hospital with additional care pathways, length of stay is decreased. West Virginia has the third oldest population in the US, with 20% of its residents over the age of 65. Using age alone as a criterion for increased level of trauma activation, specifically full trauma team activation, would overwhelm our trauma center's resources. Even if we made the age 80, it would more than double our full trauma team activations. Instead, we have developed a robust quality initiative through our PIPS program. We have removed advanced age from our lowest level trauma activation. We also mandate multidisciplinary consult with medicine or geriatrics and a close inspection of those undergoing general anesthesia for a planned upgrade to the ICU for postoperative care. We then track the timeliness of these consultations, physical therapy and occupational therapy assessments, initiation of discharge planning, medication reconciliation, and efficiency of movement out of our resuscitation area. In 2020, we initiated a new hospitalist service as a collaboration with trauma and orthopedics for elderly patients with isolated fractures. This has facilitated the cohorting of these patients onto one service housed in the trauma or ortho nursing floors with an order set that includes trauma elements such as DVT prophylaxis, and trauma follows these patients for up to 5 days in the hospital. These efforts have resulted in favorable mortality outcomes for our patients, as evidenced in our center's TQIP benchmark reports. In conclusion, the fear of under triage doesn't warrant moving to an expensive situation of over triage.
Okay, well, thank you, Dr. Knight Davis. At this point, I am a little confused. I was totally on board with the idea of aggressive triage after Dr. Poslunszny spoke. Now I'm not so sure. So, Dr. Adams, can you help us? Can you tell us what we're supposed to be doing for our injured elders?
All right. So, get there to advance. Are we really at odds here with triage criteria in one corner and hospital protocols in the other? Do we need to put Dr. Poslunszny and Dr. Knight Davis in the cage to fight this out? Maybe. Or is this going to be one of those ongoing disagreements in medicine and trauma resuscitation? Well, maybe they are both right, and we need to just stop arguing about it and do everything both of them talked about. Well, my take on this is I think you need to do you, and you need to do what works for your program. I'm going to argue that maybe there are different answers for different programs and that there's no one solution that's going to fix everything. Just think about the number of variables at play as we compare even the various institutions of the people here on the presentation today. So Dr. Poslunszny is at Northwestern in Chicago. It is the third largest city in the United States, has almost 3 million people, actually 9.5 million in the greater Chicago area. but 10% of the population of the city is over the age of 65. In Houston here, I'm fifth largest city with 2.5 million, but 7 million in the greater Houston area, also 10% in the city over the age of 65. But you look at West Virginia, this is a state of 1 million in the entire state, but it is the third oldest, so 20% of their population over the age of 65. And then with Dr. Digiacomo in Long Island, so 7.5 million on the island, New York's right over the bridge, 9% of the people in the city over 65, but 20% of their patients are over the age of 65. And then even just aside from the characteristics of the cities where we practice, if you look at the busyness of each of our level 1 trauma centers, we have very different levels from 400, 500 to 2000 of level 1 activations. So my argument here is that there is not one size that fits all. So let's take another look back at Dr. Poslunszny's slide from earlier. He broke down the geriatric triage into 3 stages: the pre-hospital, the post-transport, and then the hospitalization. So really, as you're looking through all of this, the goal is, how do you find the at-risk patient, that geriatric person who needs appropriately timed evaluation and intervention? And then how do you get them to the right place and the right people in the hospital that are going to care for them and give them the best chance of survival? And given that we all have widely different hospitals and trauma experiences, finding the right plan is a bit like finding Waldo, except maybe this time it's Betty White. So what are some of the variables in the pre-hospital setting? So some of us have one major EMS system. Others may have multiple. They all might have different trauma activation levels to determine which hospital level they go to. So perhaps this is an opportunity to create some better consistency in the pre-hospital setting. Can you work with your RAC and coordinate the activation criteria, educate the EMT and paramedics on the warning signs for people who are maybe higher risk and need to go to a higher level of hospitalization? Another question: how many hospitals are in your catchment area? Does the EMS system have lots of choices of where to take people? As you can see from this paper from Dr. Crandall's group that was published in TASCO, New York has 16 level 1 and 2 hospitals. Here in Houston, I'm the 4th largest city, but I only have 4, actually 3, I think now. And so there's a wide variability in the number of hospitals, even though the size of the cities is large. Does it matter which hospital you go to, as long as it's a trauma hospital? Dr. Cooper's group would argue yes, as they have found that in hospitals that have a higher proportion of geriatric trauma patients in their mix, had a lower mortality and a lower failure to rescue. So what about after they get to the hospital? The post-transport or the team activation? Well, as Dr. Poslunszny said, we have known for some time that in older trauma patients, the traditional vital sign cutoffs, heart rate of greater than 120, systolic blood pressure less than 90 are unreliable. So do we just change our cutoffs based on the age criteria? That is, in fact, what the geriatric TQIP guidelines suggested. While that might work for some hospitals, others it would send into an absolute overload. Again, Nassau or West Virginia, where 20% of the population is age 65, that may overrun them. Or a high volume center that may be struggling to keep up as it is. In Houston, we have 2,000 level 1s every year. Much like Dr. Knight Davis just presented, if you add an age-related trigger to just your level 1 activations, even if it's an over 80, you can overwhelm the system. So you have to know what effect that would have for your experience. So maybe rather than outright activations, you try a delayed approach. So figure out who needs the extra attention and then upgrade them to get the trauma team involved earlier. So after they get to the ER, maybe brief evaluations using exams or labs, for example, that might lead to upgrades or level 1s, or maybe trigger an urgent consult or a geriatric alert. These patients then probably need to be seen within 30 minutes by the trauma team, and that can be a way of getting some age-adjusted criteria that doesn't fully overburden the system and help select those that are higher risk. It does still, though, require someone to be looking at the patients beyond the triage vital signs. Someone has to draw the labs, has to get a history, know if they're on anticoagulants, etc. So the success of this approach is going to probably depend on the staffing and the level of involvement of your emergency room partners. How well do you collaborate with them on geriatric trauma? Are there champions for geriatric care within your emergency medicine department? Do they have the capability to create rapid evaluation algorithms for the older patients that arrive in the ER and act on those and then therefore upgrade as necessary? I can tell you in my own experience, we're lucky to have some great research and protocol partnerships with our emergency room and emergency medicine department. Our trauma research group was concerned with unrecognized occult hypoperfusion in our elderly patients. So we partnered with them and we did an early assessment of hypoperfusion using base deficit of less than -2 as a marker. Using the traditional vital signs, the heart rate 120 or systolic blood pressure less than 90 was defined as shock. But if those were normal, but the base excess was less than -2, we found that was occult hypoperfusion. And as you can see here, the patients that are in green there identified as having occult hypoperfusion, so the normal vital sign range, had a higher probability of mortality and major complications than did even those who were known to be in shock, probably because they were not recognized as needing resuscitation or needing that earlier intervention. So again, early identification and intervention is like the key to improving the outcomes. So once you've identified these individuals that are higher risk and you're moving out of the emergency room, the next question is, where do you admit them? To what level of care? For those that are older, more frail, do you automatically upgrade them to a higher level of care with more nursing support? Maybe like in Nassau, where they admit them to the ICU and then have them for 24 hours or overnight. And as they evaluate them, if they're doing well, downgrade them into a very specialized geriatric unit that's going to take care of them. If you're running already at near capacity in your ICUs, however, with patients with high injury severities, that might not be practical. Some hospitals have also developed specialized units of care designed specifically for geriatric admissions. You can have age-specific training for nursing, maybe increased presence of PT, dietitians, and speech therapists, for example, and increase the triggers for evaluation and therapeutic needs of these patients. So who is going to admit the patient wherever they're going to go? Is it going to be trauma? Is it going to be a geriatrician? Is it going to be a hospitalist or medicine, whichever you have stronger in your hospital that can do the admissions? Or maybe you do geriatric trauma service with a hospitalist consult. So as Dr. Knight Davis mentioned, they have a geriatric hospitalist fracture service that admits isolated orthopedic injuries. In Nassau, as I said, they go to the ICU and then come down to a specialized unit. In Houston, we have somewhat of an upgraded floor unit for geriatric patients. Or maybe you admit to trauma but have a geriatric consultation, whether it's mandatory or triggered or conditional on certain, or even just by attending preference. So if there's a geriatric consult protocol, as in fact the TQIP guidelines suggest that programs should develop these criteria and include geriatric expertise for multidisciplinary trauma care. But can your geriatricians support that in your hospital? I can tell you, I'm in a major medical center in a large urban city, and I called for geriatric consult and found out they weren't at that time staffed adequately to cover consults. They didn't have that much of an FTE covered by the hospital. We've since fixed a lot of that, but we also have to realize that the geriatricians are also dealing with all of the non-trauma patients throughout the hospital, and they don't have the personnel to handle everything that's coming in. So they're also strapped. So then you have to partner with others that can also help you. So hospitalists that perhaps specialize in geriatrics are a great resource. Again, knowing who is available at your facility is important before you make plans on knowing who you want to ask to help. So you're looking at all of these things for yourself, for your own institution. How do you know if you're doing okay? Well, first, look at your data. Look at your outcomes, the system you have, the triage criteria that you currently use. Who are your partners and the stakeholders in the care of your geriatric patients? Where are the problems? And then what is within your power to change? The most important thing, I think, as both speakers earlier pointed out, is the rates of under triage. You can look at your rates of unexpected ICU admissions or readmissions, unexpected deaths, complications. Looking at the time of discharge, was there a loss of independence or function at the time of discharge? So you don't want to have under triage, right? So what if you just aim too broadly and just say, forget it, we're going to get all of them in here? Well, then what impact is that going to have on your program? And I think Dr. Knight Davis highlighted a lot of this already, but you have the over triage effect, huge cost to the hospital, huge cost to the patient. But more importantly to me, and what she presented, was the volume of consults that did not need that level of care, and it overwhelmed the trauma resources and actually had the reverse effect by having people then less interested and less paying attention to those traumas because they thought, it's just a geri upgrade. So it's the exact opposite of the effect that we were going for. And the most important thing is, again, use your data. And if you contribute to TQIP like most of us do, it's going to give you feedback on your performance compared to the 875 other trauma centers nationwide. There are 3 specific elderly performance benchmarks that you can look at. There's the elderly trauma, elderly blunt multi-system, and then isolated hip fracture. And so I want to tell you a little bit about how we used our TQIP data at our center to help change our practice. So this was presented at the TQIP conference last year. We identified a significant problem at our institution. We thought we were doing great. Our risk-adjusted mortality in most of the areas was in the top 2 deciles, but in the elderly cohorts, we had worsened to the 10th decile for both elderly blunt multi-system and the isolated hip fracture. We were in the 7th decile in elderly patients. So, we were shocked. How do we do this? And so we did a lot of things in response. So we created a geriatric trauma task force. We pulled together all of our stakeholders. We looked at trauma, ortho, emergency room, anesthesia, hospitalists, geriatricians, nursing, pharmacy, RT, PT, OT, speech, dietitians, got everybody together. And we really worked together as a performance improvement project to figure out what we could do. We did a lot of chart audits, identified clusters of at-risk patients within our patient population. We did, again, the hypoperfusion study, like I mentioned already, identified some urgent consult protocols that we could utilize in conjunction with emergency room evaluations. We created algorithms, EMR bundles, and then eventually we created a geriatric trauma service in partnership with our geriatric hospitalists. And they actually became part of our trauma team. So they come to our M&Ms, they come to our faculty meetings, and they're part of the group, and it's a true partnership there. They admit probably about 10% of our patients. We also still have our geriatric hospitalists that also still admit probably 30% of our patients as well, a lot of the isolated orthopedic injuries, et cetera. And our trauma service still admits another 40% on top of that. So we're all very involved in their care and have a lot of time to kind of look and improve how we provide that care. So through all of this effort, we were able to change enough care at our institution such that the elderly cohort improved by the spring of 2021. You can see we actually made it into the 1st decile for both the elderly and elderly blunt systems, and then 2nd decile for isolated hip fracture. We continue to do monthly PI quality improvement projects and follow all these patients to make sure that we're still continuing to uphold those same standards and find additional ways to improve the care of our patients. So in summary, I'd like to say, I think that the solutions that you find need to be customized. They need to be for your institution based on your needs and what your capabilities are. And you need to remember that the solutions from other programs might not be right for you. You have to customize a response based on who you are. And as a trauma community, I think it's important for us to continue to celebrate and utilize our various strengths as different institutions and find ways to improve the care of our at-risk patients in a way that fits each of those strengths.
Dr. Adams, thank you very much. Thank you to you and to our other panelists, Dr. Poslunszny and Dr. Knight Davis. I do have a couple of questions for you all to argue, but before I do that, I want to introduce Vanessa Ho. She is one of the other vice chairmen of our geriatric committee. She was tied up a little earlier today, but she's thrilled she's able to join us. And I think you had something you wanted to comment on.
Yes, I really loved all of the panelists and their presentations today. And I think it's clear from the chat that this is it's not only controversial, but it's a topic that everybody deals with and has to figure out how to do this better. And I think one of the really interesting things about what's been said so far today, and this is something that we talked about as a group as well, is that triage isn't just happening at the door. There are opportunities throughout the hospital stay, from pre-hospital all the way through discharge, to make this better for our older patients. And so thinking outside the box, which is something that's happened and you've seen in every talk today, thinking outside the box of where you can find the places to improve in your own institution is, I think, a way to tackle this. And it's been super interesting tonight. So thank you, everybody.
Thank you, Vanessa. So a question for the panelists, and let you all kind of jump in as you wish. And this is based on a question that was directed to Dr. Poslunszny. when a patient's identified as frail, do they undergo more aggressive care? And what does your pathway do differently for this patients? And it got me thinking about, what about that elder who fell 3 days ago or 2 days ago and now shows up in the ER? How do you triage these patients, and what are your pathways for them? Joe, you want to take that first?
Sure. For the first question about what do we do for patients that have screened as frail, our frailty pathway includes an immediate consult to PT, OT, a recognition of the patient being frail to social work so that they can start on working both with the patient and the family on their discharge, and an immediate consult to perioperative medicine that the patient is frail. In addition to some other small changes to their orders. But those, I think, are the 4 key things: prompt, PT, OT, social work notification, and pre-op medicine notification. In our study, and we started this about 6 years ago, and we continue to do frailty screening in our frailty pathway for all of our patients, we significantly decreased the 30-day readmission rate, shortened the length of stay, and also improved or decreased the amount of loss of independence that these patients had. Now, whether or not that was a Hawthorne effect simply from frailty screening and recognizing that these patients were frail and the entire team coming together to address that, or whether or not that was a component of the frailty pathway as well, we don't know, because we didn't have a group that we just did the frailty screening for. Either way, it's become part of our culture that everyone on the team is recognizing patients as frail and is recognizing the increased care and attention that they need because of this. And overall, I think it's improved our care of our geriatric patients tremendously. In addition, we don't get a mandatory geriatrics consult or a mandatory medicine consult on every patient over 65, because what we've all sort of shown in our presentations is patients that are geriatric vary tremendously based on their fitness, based on their comorbidities, and we feel that it's a waste to give patients a mandatory geriatrics consult simply when they're over 65, because many of them don't need it. So we put our resources appropriately where they're needed.
Is anybody using something like the Charlson Comorbidity Score or Core Morbidity Polypharmacy Score as part of this in-hospital geriatric triage? Sasha or Jen, maybe?
We do it as part of our frailty assessments, but in the first stage of them arriving to the hospital, a lot of times you don't have access to that information. So it's hard to use that in the initial, but we do use it as we follow up with them in the first couple of hospital days.
All right. And what are you people doing about the patient who does show up 2 or 3 days later? You know, they fell on Friday in the shower, and now families brought in an 85-year-old with varying degrees of injuries.
I think a lot of it depends on how they show up. Are they in rhabdo? Are they in renal failure? Are they in septic shock? I mean, there's so many ways that can present that you really have to adjust to where they are now and figure out what to respond to.
I think, Jody, to some of the things that Sasha pointed out in her presentation is using your data to see where your under triage is happening. If that's a vulnerable population at your trauma center and in your population, that those patients that are late in their presentation are higher risk for poor outcomes, then you might want to think in terms of that population of patients for you being more aggressively evaluated. If they're not part of your triage criteria, perhaps they should be. If they're part of a lower level triage criteria, then perhaps more urgency to interact with those patients is important.
We have a relatively, at Metro Health, we have a relatively strong triage criteria, age-based triage criteria from the door. So if we have a patient who had a traumatic mechanism who meets that age criteria, they get at least a category 2 trauma, even if their trauma was remote. Now, the trauma team, when we arrive, we can immediately assess if that's worth a downgrade. And so those patients would often get downgraded, but I think we do that so that we don't miss the rhabdo patient, and those patients would get quickly assessed and moved to the ICU.
Well, that's an interesting comment. One of the questions from the audience was an analysis of the cost of under triage. And that kind of leads into a question of the consequences of over triage versus under triage in terms of outcomes. So which should we be choosing? Should we be choosing over triage and watching Sasha just drop dead from exhaustion? Or should we be under triaging and letting her get some sleep? Anybody?
I
Nobody
vote for,
loves Sasha.
I vote for appropriate triage. So I think that the under triage is what we're fearful of, but bringing under triage to appropriate triage is, I think, what our goal should be, while watching closely to make sure we don't start over triaging.
And I think that's really the key, is you look at what you believe to be your under and over triage at your own institution. If the right thing for your institution is to use age 70 as a cutoff, and it doesn't cause a burden, but it does catch those people, then maybe that's a quick solution for you. For us, it wasn't. I mean, if I upgraded everybody who was over the age of 65, I'd more than double our level ones. Obviously, we don't have to go to level 1, but I mean, just that alone, the volume that it could incur from just age is not right for us. That said, we are doing absolutely multiple things in the emergency room to try to identify them, whether it's ultrasound guided assessment of the resuscitation needs, base deficits. Someone asked in the chat about lactate. We can get the base deficit faster, but yes, lactate is another way to look at, hypoperfusion. So we've had to identify ways that we can identify. We have tried to figure out ways that we can identify those at the highest risk that is not based on age, to keep us from that over triage. But I think everyone's answer is different.
So
This gets back to what you were saying. I'm sorry, Vanessa, go ahead. I didn't mean to cut you off.
No problem. So one example of using your data at Metro, we noted that a lot of our upgrades to the ICU were occurring in older patients who had chest trauma. So they were doing okay. They had a few rib fractures, and we would put them on the floor. And many of those patients would need increasing levels of oxygen and increased respiratory therapy requirements. And so we changed our protocols to put older patients with rib fractures, and we have a score that we created. And that is actually shunting a lot of our patients into a step-down unit early. And they're getting aggressive early respiratory therapy. And now we're having many fewer upgrades to the ICU. So that's just another example of a way that you can use your data to find, that was specifically happening in older patients. So then the older patients went into our protocol of going to step down. So just another example.
Yeah, I got a question for you all about who you are, getting back to Sasha's presentation of you do you. Who are you? And also, what is geriatric? I'm 62 now, and I'm getting a little offended by 65 being defined as geriatric. I don't feel that old. Now, we know in the 40s and 50s, geriatric was men over the age of 55 and women over the age of 50. Since then, we've been saying 65. Is geriatric really 65? Is it 70? Is it 75? And if you are up to your ears in elders, whatever that age group might be, should age be a criterion? Or conversely, if you have very few elders, should age be an automatic criterion? For us in Nassau, everybody seems to be over the age of 80. So having it as a specific criterion is not so important to us. But I wonder if you're someplace, I don't know, not Houston, I guess, someplace that has few elders, maybe they would warrant more attention. What do you all think?
We use an absolute age of 70, and then if you're 65 with significant cardiac or pulmonary comorbidities, then we'll put you into our geriatric sort of algorithm with regards to some of the increased monitoring, consultations, etc. So that's how we do it in West Virginia.
And since we use an automated screening process, we use 55 to trigger the screen. And then we look at things like the trauma specific frailty index and the Charleston comorbidity index to determine then where we need to go.
I think that one of the great papers that was done was the one that I mentioned. That's a systematic review of all the geriatric field trauma criteria. And as they pointed out in their paper, some papers use 55, some use 65, some use over 70. So in order to sort of modify what you do and look for best practices, there's not necessarily a best practice out there because all these cutoffs are different. So it's hard to put these together to really know what's best to do. With that in mind, looking at the impact that frailty screen, that sarcopenia had on inpatients, we don't have that information in the field. We don't have that information necessarily immediately in the trauma bay. And so something probably has to be done where it's age plus something else that can be readily identified either in the field or upon arrival to the trauma bay that should signal that, okay, here's step one, this patient is old. Step two, this patient has other X, Y, and Z that's now going to prompt additional resources. And what those things exactly are, I think is unclear. And you may need to modify it to what your local population looks like.
Vanessa? Anything to
We
add?
do use a specific age of 65 and older for ours. And then we have in the hospital specific criteria that would trigger either a geriatrics or a palliative care consult because we know that many of our palliative care individuals are geriatrics trained and many of our geriatrics individuals are also very skilled in palliative. And I think it just goes to show that I think hospitals probably do best with what they see often. So if you're a hospital that treats a lot of young patients with penetrating trauma, then your geriatric outcomes are probably not that great. But if you're in a hospital that treats a lot of geriatric patients, then everybody in the hospital is going to be very familiar with frailty and Charlson comorbidity scoring. So it really is important to look back at your institution and see what you have.
All right. Well, I got some of the questions from the audience are very pointed at this point. One of them is, and I guess this goes more to Sasha since you guys are running it this way. How do you decide who gets admitted to the trauma service and who gets admitted by the geriatrician? I know for me, that makes me nervous having any injured patient not under my immediate control.
So we have 3 different directions our patients can go. One is to the trauma service, yay or nay with a consult. One is to our geriatric trauma hospitalists. Now, since they're part of our team, they are hospitalists, they are trained by them, but they participate in our morbidity mortality. They're kind of a small group that's associated with us. We give them a little bit more than we would give out to the rotating hospitalists that are oriented toward trauma. The trauma hospitalists are different people, but they're not part of our side of the team as much. A lot of what they will take is the like isolated fractures or, maybe even some minor kind of multi-system, like they have, ankle fracture plus maybe 1 or 2 rib fractures and something like, lacerations and facial fractures that are non-op. Again, this is the comfort level of your hospitalists. It's the comfort level of you. And I will tell you that regardless, our rule is if they call us and say, can you take this person back? I'm concerned. The answer is yes, 100%. And then we work with them to make sure that they're comfortable taking care of the patients that we do send them.
Our geriatric fracture service is a hospitalist run service, and they have to be an isolated extremity or orthopedic fracture, except we don't want patients with rib fractures for similar reasons that Vanessa had mentioned, as far as just the need for aggressive management, but like isolated hips or ankles or wrists, or even minor pelvic fractures, we will let those patients go to our geriatric fracture service. And then trauma follows those patients while they're on that geriatric service for about 5 days.
How do you address the issue of non-surgical service admission for these patients?
As part of our PIPS process, we just
Right.
make sure for those patients, we make sure that the protocol was followed, that their DVT prophylaxis was started in a timely manner, that their operative intervention was in a timely manner. And it's per our protocol. So as long as there's no deviation, then that's just a simple review. They're closed out very quickly.
We do similar, but we also review anybody who had an IS over 9 as part of that to make sure that they were appropriately admitted to that service. Of course, the ISS doesn't come up till later. And then by having the hospitalists on our team, it's not a non-surgical team, or it's not a non-trauma team since they're on ours.
With regard to the question of under triage, we're not typically called for the under triaged patient initially. That's the whole, I guess, part of the definition of under triage is that the emergency department is doing their evaluation. Somebody in the audience had commented that triage should be dynamic and flexible, and that under triage can be easily upgraded on initial evaluation, but that requires someone doing that and calling us in. What are the markers that the ER should be looking at for a patient as potential under triage? Is lactic acidosis, hypoperfusion, gastric acid of the ER attending? What's the appropriate indicators?
Spidey sense, don't forget Spidey sense. Very important.
Agreed. Joe, what do you think? What are you doing out in Chicago about that?
So we don't have any set criteria necessarily. It's if a patient arrives to the emergency room and there was no trauma activation, then it's the discretion of the emergency room team to activate that as a trauma. But there's no standard criteria that we actually have. So when I mentioned before, like, what are the X, Y, and Z that come after age? At that, it's just the experience or the concern of the emergency room physician.
I think we're all looking also at some of the updated criteria from the Committee on Trauma for urgent consults. I know that they've recently changed. I'm not going to get them exactly right because we were just reviewing them this week, but like different pelvic fractures, different neurosurgical injuries. And so this may be in a way at your institution to think about, do we want to incorporate any age specific or age related criteria into the urgent consult process that we're all going to be adapting to, based on the new COT recommendations.
Vanessa, what's going on out in Cleveland? How do you address under triage?
We have a very aggressive triage policy so that we probably see everybody.
So your over triage rate is
we're
what,
over triaging,
50%?
which works well for us, and luckily we have the staffing to do that. We also have a very aggressive ED communication and PI process. And we have additional PI meetings, not just our main PI meeting, but we have additional ED specific PIs where we go through cases that were over and under triaged so that there can be very tight loop closure with under and over triage. So anything that needed to be upgraded, anything that was downgraded inappropriately, they all get reviewed very quickly, as well as with our Lifelight. So pre-hospital, we go through those numbers all the time. And so that's how we keep tabs on our numbers.
So what is your over triage rate roughly? And I'm asking you this just so I can watch Sasha's face when you say 75%.
I don't know the number, so I will have to get back to you on that.
Would over triage break your back, Sasha?
Yeah, I just asked my TMD yesterday, like, hey, if we did this as a criteria, how much would that affect us and how much over triage should we do? She's like, I don't know, let me recover from my heart attack first and we'll talk about it. So she couldn't even give me a number.
So Jen, out in West Virginia, over triage, under triage, what do you think the appropriate rates ought to be? I guess it sort of encompasses all trauma patients, but with specific regard to the geriatric.
Yeah, I mean, lucky for us, we're kind of the only game in the whole state. So there is a small community hospital in our town. And so we're pretty careful to watch in our immediate community. If the local EMS takes injured patients to the non-trauma center emergency room, we watch those numbers pretty closely. But if they don't meet what our standard criteria for paging out or activating the trauma team, that's what we use as our under triage rate. And I think overall we do a pretty good job of that.
Well, it seems to be all the questions we have, all the questions I have. Do any of the panelists have questions for each other? It's your last chance to get your stabs in.
This was a lot of fun.
It was. I've certainly enjoyed it, and I want to thank you all for taking the time to spend with us and share your thoughts. I find it interesting. I've got notes written for things I got to look into tomorrow. Maybe we'll be presenting it at a TQIP meeting or a TCAA or something. I have no idea, but it certainly gives me more things to think about. So I appreciate all of you to taking the time to do that today. So I guess at this point, we are going to say goodbye, and we will see you all next month. So thank you very much.